So mine is the first talk. I will give brief introduction to the evolution of pediatric and neonatal ECMO. What are the concepts? What is the reality? And how to set up a uh, pediatric or neonatal ECMO center. My objectives for today are about evolution of neonatal ECMO, how it progressed over the years, what are the concepts behind it, and setting up the ECMO. Though we talk about ECMO um, starting in the last 50 to 60 years, but the roots have been there for quite a longer period of time before that. What I mean by this is people have been thinking about the process of extracorporeal oxygenation, how to make cardiac bypass possible initially in experimental animals and afterwards in humans. There was a stumbling block in the experimentation period till 1920s. This was a time when MacLean invented heparin. After the discovery of heparin and anticoagulation process, it became relatively easy to prevent clotting of the blood in the circuit and make further progress with the extracorporeal techniques. With respect to the cardiopulmonary bypass, uh, John and Mary Gibbon, they made a remarkable imprint on by the discovery of heart-lung mission, as we have common foundations at this stage. This happened in the 1930s and became effective in 1953. Then Dr. Bob Bartlett uh, in 1975 put in neonate on ECMO for persisting pulmonary hypertension secondary to meconium aspiration. We will briefly go through that story. So initially, uh, as it was started in 1989, it was a central ELSO for all of us. ELSO standing for Extracorporeal Life Support Organization. And in 2013, we started our own chapter of South and West Asia chapter of ELSO, which is one of the five sub-chapters of ELSO. We're still guided by the parent ELSO. Over the centuries, in the last 3 centuries, William Harvey discovered circulation of the blood in 1628. After 3 to 4 decades, Richard Lower he kept dogs alive by transfusion of blood from the other dogs. 1818, James Blundell he performed first successful blood transfusion of human blood to treat postpartum hemorrhage. And in 1900s, Carl Landsteiner discovered the first three human blood groups A, B, and O. Now we know there are other minor blood groups are also existing there. So briefly, I dealt with John Gibbon. In the 1930s, he started his research, which culminated in repair of the atrial septal defect in 1953, ending 23 years of the apparatus design. So in 1972, Bob was instrumental in putting a 2-year-old boy following mustard procedure for a transfusion of great arteries. But in 1975, he used it for respiratory ECMO uh, by putting Esperanza on ECMO at that time. So she had persisting pulmonary hypertension and refractory hypoxemia following meconium aspiration syndrome. She was the first baby to go on to ECMO, survived and did very well after that. This was Esperanza on her 21st birthday. So after the first case of Bob in 1975, there was a conference in 1979 with further cases of ECMO, the first neonatal ECMO conference in the United States. In 1980, Bob uh, started putting further babies on ECMO as his continued practice, and it has grown to few cases per month. 1986, modified design trial was done in USA. 1989 was the birth of ELSO. These are the standard landmarks. By 1981, Bob's group treated 45 newborns with a success rate of over 50%. It led to establishment of more ECMO centers, and in the next 5 years, 750 neonatal cases were reported at 18 centers with favorable success rates of around 80%, a vast improvement from 50% in 1981 to 80% in 1986 over a period of 5 years. Subsequent trials followed. Boston trial again showed 97% survival in the ECMO group versus 60% survival in the conventional group, though the numbers were small in this group. Then came the UK collaborative neonatal ECMO trial. This is a landmark trial. It was done in United Kingdom with 4 ECMO centers as the base, with Hartling ECMO Center in Leicester as one of the major centers which came up at this time. This was a positive trial, and as a result of this, worldwide recognition for ECMO has been established, and ECMO started growing after that. Initially, to start with, it was neonatal and pediatric ECMO. Later on, the principles were attributed to the adult ECMO as well. Currently, adult ECMO has got more popular than neonatal and pediatric ECMOs. We have two types of ECMO, as you know. We know venous ECMO and we know arterial ECMO. In general, for respiratory reasons, it is venous ECMO, and for cardiac reasons, it is arterial ECMO. Postoperative cardiac surgery wise, failure to come off bypass, these are certain indications why we tend to put babies on ECMO postoperatively. ECMO for cardiac support, anticipating recovery when cardiopulmonary bypass is for longer period of time and it is difficult to come off for cardiopulmonary bypass. Stabilization for a definitive cardiac procedure in an unstable child, such as atrial septostomy. If the pH is very abnormal with a significant base deficit, it is better to uh, look after this baby on the ECMO prior, stabilize the baby on ECMO prior to doing any of these procedures. Other indications are myocarditis, cardiomyopathies, uh, arrhythmias, ECPR, etc. So this is one baby where neonatal cannulation is being done into the internal jugular artery. It was all into the vein. It was already done, and now they are attempting to put it into the artery. So the worldwide, the number of cases uh, which have gone on to ECMO have been increasing year by year. This is a cumulative data. That is, all the ECMO centers who have been doing ECMO are presenting their data here. In the neonatal ECMO, more than 35,000 cases have been done with the 72% success rate. This is from, as I mentioned, cumulative data. And cardiac wise, 11,600 cases have been done with 45% success rate. ECPR as well, close to 3,000 cases with 42% success rate. Similarly, pediatric numbers can be seen as well. So many technical advances have happened in the last 15 years. So this period is called as ECMO 2 now. Circuits can be easily primed. Cannula implantation through Seldinger method is possible, and pump is easy to use as well. Bob calls this period as ECMO 2. Now the low resistance lungs can be used with low pressure, safe pumps, less thrombogenic. Inherently safe, self-regulating circuit needs only a flow switch, and less number of nurses and ECMO specialists can look after more number of babies as well with this. Safe, easy vascular access is possible. So this is a picture showing how we used to run ECMO in the 1990s. When I was at Glenfield Hospital, Leicester, there is a baby on a neonate on ECMO on a roller pump. So this was the period of roller pump ECMO. From there, we moved on to centrifugal pump ECMO now. Majority of the centers in the world do centrifugal ECMO. The ECMO consoles have been miniaturized. The very small circuits are small as well. That eliminated many problems and due to thrombogenicity, volume of distribution, pharmacokinetics and dynamics, etc. So the miniature ECMO pumps, it is becoming more and more easy to do the ECMO. Coming to setting up a pediatric or neonatal ECMO center, probably my concepts are from the way I was trained. Like I was in a combined center catering for the pediatric, neonatal, and adults program, because for ECMO, numbers are the most important one. If you do 3 or 4 neonatal cases in a year, that is not at all sufficient. ELSO recommends doing at least 20 cases per year as a bare minimum. So cases are very, very important. I know pediatric centers and neonatal centers could be different, but ideally, by combining with the adult team, you might get better numbers unless you are able to generate up to 20 cases. I'm sorry, just 1 second. Hello? Yeah, yeah. Refer. I'm teaching. I'm teaching. I'll come back. I'm sorry. So, motivated, organized professionals as a team are very important. Um, Organized professionals are important, but a team is a group of individuals who understand each other and supplement for the um, shortcomings of the other personnel. So that is a team. So when professionals are able to function as a team by supporting each other, that's what is needed for running a successful ECMO program. Facilities are obviously needed. At least 2 to 3 ECMO pumps will be minimum, bare minimum. ECMO consoles. Training is essential too, and afterwards, learning, relearning, audit, and further improvements based on that is very, very important to run successful ECMO program. Having facilities for ECMO, in my opinion, is ability to provide maximal conventional management, high frequency oscillation, inhaled nitric oxide therapy, retrieval facilities, and conventional retrieval or mobile ECMO facilities as well, multidisciplinary team management, protocols, uh, equipment, supplies, etc. So all these things are inherent for an ECMO program. Whether you start a combined ECMO program or pediatric stroke neonatal ECMO program, these will be the bare minimum. The ECMO team generally consists of ECMO specialist nurses. I consider them as the backbone of ECMO. They are the ones who will stay with the patient in shifts day and night and inform us in case of in any shortcomings. So they are the pillars of safeguarding ECMO program. Perfusionist, I mentioned one instead of many because it depends on the availability really. Even 1 or 2 perfusionists also should be able to help you. ECMO intensivists are the motivated people among the physicians who are interested in carrying on with the ECMO. They are needed. ECMO surgeon for cannulation sake, and more importantly, the patient. They also will become part of the team as goes by. How many people do we need for running a safe ECMO program? That's a very interesting concept. More the merrier, of course, but people who are motivated, they know focused people, focused individuals, they are the ones who are needed for running a program. And as I said, in a team as defined by a group of individuals, professionals who are able to support each other by overcoming the shortcomings of each and every person. So, a handful of dedicated men and women are needed. They are highly trained, they know what to do, good experience, commitment, and communication. When I was at Kim's Hospital, uh, Hyderabad, this was a decade ago. At that time, we had a group of pediatric intensivists, neonatologists, cardiothoracic surgeons, adult intensivists, cardiac anesthesiologists, cardiologists, perfusionists, okay, and other people needed like pediatricians, nephrologists, radiologists, etc. But the ECMO nurses are very important as well. The PICU and MIC nurses here. So this was a team understanding and able to go ahead as a team. Preceptorship is very important before we start putting the patient on ECMO. Everything can be done. There's nothing that is impossible. But preceptorship, learning and guidance is very important. Preventing infections in our uh, state of affairs is very, very important because 40% of the mortality in our ECMO patients is secondary to infections. It is not an exaggeration if we say we live in a bacterial world where we will never be able to stay ahead of the mutation curve. So if we use powerful antibiotic, bacteria will become much more powerful by inventing their own ways of overcoming uh, these antibiotics by creating their own resistant strains. Avoid accidents, learn by simulation, prevent air embolism, and safety is the most important thing for running a successful ECMO program. So the way forward is bring down the cost as they may not provide you the useful environment for continuing the entire duration of ECMO if there are financial difficulties. Do justice for taking up the medical profession, learn, practice, and under supervision, share experience, improve transport facilities with nasal integration. You should be able to build up your own ECMO program. Help is always available, so uh, you can discuss with colleagues and teams for establishing your own ECMO program. But as I said, the most important factor is about the numbers of ECMO. Thereby, you can work towards building up your own ECMO program. If you have any questions, I'm